Okay, great stuff. Okay, I hope everybody can hear me. But it's my great privilege to welcome you all to this week's deep dive session. And we've got a special guest today, and I really look forward to this topic, especially because it's my favorite topic, of course. But before we get there, I just want to quickly remind everyone of a few important things. So first, the sessions are recorded and the recordings are found on our bloodsa.org.za website. And if you want to quickly go and have a look there, there are lots of videos related to the Monday deep dives already. So we tend to move all the deep dive sessions there for those who can't make it. Please, we encourage you all to make this an interactive session. So please put questions, comments in the chat box. When the time arrives, put up your hand, please speak up. We are here to figure out how to manage our patients better, make diagnoses better, and especially with iron, that can be very tricky at times. This is a great moment, an opportunity to bring your difficult questions. So, and let's see what we can learn. If you are not on the regular mailing list and somebody just forwarded you the invite on a WhatsApp or something today, please send an email to Melanie Davids to make sure that you get added to the mailing list for the long term. And then you'll get the invite well in time with the links and everything every week. If you're from South Africa, the CPD points are automatically submitted to the Health Professions Council, so you don't have to worry about that. But it is important that you register, that you attend with your own registered Zoom account. If you're 5 people sitting in a group, only the person who registered is going to be getting that CPD point. And if you're from another country and you need a CPD certificate, maybe a PDF or something, just email Melanie and we can organize that. So the Zoom system automatically measures attendance time, and you need to attend for an hour to qualify for the CPD point, just for those who might have questions on that. At the end, there will be an opportunity to provide feedback when you before you go, and please, it's anonymous. Just give us some feedback. We want to make this as best as possible and improve every time. So let us know, and we'll see what we can do. Just want to remind everyone of our upcoming hematology conferences. So the SASMO SASETS conference is happening soon. Very exciting, 5th to 7th of April at the Cape Town International Convention Center. Please make sure you register for that and come and join us here. I think it's going to be a great meeting. There's also the International Donor Registry Conference and the World Marrow Donor Association meeting happening in Cape Town this year from the 25th to the 29th of June. And as you can see on the bottom left, if you're a member of one of the local organizations, you're part of SASET, such as or Blood SA or Satiba, then you can actually get a significant discount. Also want to give you an early reminder or heads up about the Hem-Onc meeting that will be taking place from the 13th to the 15th of September. So, and maybe this is a good opportunity to let everyone know. I see we've got 130 plus people in the room. So maybe I can share with you that we've been a little bit the victim of our success because of the huge attendance of more than 300 people at last year's conference. We were unable to find a venue in a good place big enough to handle the whole group. And that's why we're back in Cape Town this year, but now we've got to work long in advance to make sure we get a good space in Gauteng for next year, which is where it was actually supposed to be, but we couldn't get a good spot for the times available. Everything was booked up. So welcome back in Cape Town for all of you, hopefully that will come in September. I want to say a big thank you to the team working behind the scenes. The one person I'm missing on the screen is the one that's been very involved with this lately, is Bridget McMillan, Dr. Bridget McMillan. But together with Estelle and Gerdine and Melanie, they've been doing a fantastic job over the last few years since we started this in COVID times. So thank you very much, everyone. It's a huge work, and special thank you also to Blood SA, who helps a lot with getting the videos online and hosting the website, etc. So it is the moment, and it is very exciting once again to get a South African graduate that has made his mark across the pond, as they would say if we were in the UK. Professor Mark, is it Chaitovits, Mark? How do I correctly say that?
In South Africa, I was known as Chaitovits. So yes.
And okay, you're going to tell us just now what you think.
Chaitovits, great, thank you.
Great. So Mark obtained his medical degree at Wits. There are many Wits people in the room, Mark. In 2001, he relocated to the States, where he completed his residency in internal medicine, as you can see at Albert Einstein Medical Center, and then did a fellowship in hematology and oncology at Thomas Jefferson in Philadelphia. And he's an assistant professor now back at Albert Einstein College of Medicine, with a special research interest in iron deficiency and its management, and he's also director of iron infusion services. So I'm delighted to have you with us, Mark. We are on a mission to educate everyone in South Africa and beyond on iron and iron metabolism and deficiency and treatment and screening and so forth. So I'm sure we're going to have lots of conversations today. I see we've got a nice number of people in the room, and I really encourage everyone to come along, give your questions, put your difficult cases, your difficult iron studies in the chat box, and let's wrestle with it together. So with that, I'm going to stop sharing. Mark, you're welcome to share your screen, and a big welcome and a big thank you for making the time to be with us today. And I hope you enjoy the time you have back home.
Thank you, Professor Lowe, for a very kind and flattering introduction. This is very exciting for me too. As I think you can say the same, I think iron is probably one of the most exciting things for me to talk about. Yes, I'm kind of nerdy in that way. And I can only echo what you've said, that I look forward to a vigorous discussion, and hopefully there'll be lots of interaction. As a disclaimer, I will say that I'm not a scientist. I'm not a lab person. I'm very much a clinical hematologist. So there definitely will be a focus on, the diagnosis and management of iron deficiency. Roughly half of this talk will be a general discussion about some of the issues. And I'd actually emailed Vernon earlier, and he pointed out some of these issues, and I'm going to try and touch on some of the questions. And then I'll finish off with just a little bit of the work that I'm doing and some of the innovations that we've introduced at my institution to facilitate the treatment of patients with iron deficiency. That's my first disclaimer. My second disclaimer is an apology that I will be spelling anemia and hematology incorrectly for the rest of this presentation. And I did think about changing especially, but it just seemed too much work. So just bear with me. That's my apology. Okay. I think every presentation on iron deficiency begins with a slide similar to this, which talks about the real prevalence of iron deficiency, which is a global phenomenon. It's been identified by the World Health Organization as a priority for management. These are the numbers that are typically quoted, that roughly about 30%, especially of women in the menstruating age, suffer from iron deficiency, and about 10% of those actually have iron deficiency anemia. In the United States, the numbers are somewhat different, a little bit lower, probably about a third of that. But as you can see, there's significant variation across both socioeconomic strata and across different ethnicities, with Mexican or Hispanic individuals having a really high prevalence of both iron deficiency and, as a consequence, iron deficiency anemia. The causes of iron deficiency are multifold. This is from a very often cited review by Clara Camashella, but I'm going to, as a clinician, I'm going to simplify it for you. There's really not much that causes iron deficiency in our clinic, at least in my clinical practice. The vast majority of patients that I see are patients who bleed, and of those are women who are experiencing heavy menstrual bleeding. In outside of that population, in males, certainly gastrointestinal bleeding, in elderly patients, typically from angiectasias, or patients with Osler-Weber-Rendu syndrome, are common presenting patients in our iron deficiency clinic. The other side of that equation, patients who don't absorb very much, really is a minority. For reasons which will become clear when I speak more about the physiology of iron deficiency. But just to know that probably one of the most important contributing factors within our population is patients who've had bariatric surgery, which we have a large population within our community in the Bronx. And as everyone knows, if you don't have a stomach, you're not going to absorb iron as effectively as if you did. Even patients who haven't had actual gastrectomy but had other procedures such as gastric sleeve, those patients also tend to have impaired iron absorption, primarily because of the change in transit through the stomach. We always screen for patients with celiac disease in patients with unexpected iron deficiency. Inadequate diets, I think, is relevant, particularly in the pediatric population. In adults, it's exceptionally rare, if it ever happens at all, that a person will become iron deficient just from poor diet. This little reference at the bottom is actually a case report of a psychiatric patient who went out of his way to avoid all foods that had iron, and it took about a year or two before he eventually became iron deficient. And when I discuss the physiology, the reason for that will become apparent. So this is the famous iron kinetics cycle. About 1% of our red cells are used up or die on a daily basis, and our body requires about 20 to 25 milligrams of iron to reconstitute those lost red cells. Fortunately, we don't have to absorb that amount of iron to replace these red cells because of this recycling phenomenon that dying or senescent red cells are eaten up by reticuloendothelial macrophages. Their hemoglobin is processed, the heme is processed, and the iron is re-released to the circulation, again taken up by the bone marrow and then delivered to the developing red cells. Any excess iron that comes into the system is stored, basically sent to the liver and to other reticuloendothelial cells and Kupffer cells in the liver, where we have a buffer zone. In terms of what's actually going in and out, under normal physiological conditions, very little, 1 to 2 milligrams a day. And you'll always see 1 to 2 milligrams a day because 1 milligram is basically our physiological obligatory loss from mucosal sloughing from the gastrointestinal tract. And in women who are menstruating, a normal menstrual cycle, a normal period should constitute about 30 milligrams of iron if it's a normal volume. So that would take it up in a menstruating woman to 2 milligrams per day on average. And that's easily replaced. With even an iron poor diet, we easily will ingest that amount of iron. There's no mechanism or no physiological mechanism for getting rid of iron. So in situations where we need more iron or we need less iron, all the regulation happens on the side of absorption. And because iron is toxic, if absorption is unbridled, so to speak, and if we absorb too much, it can quickly lead to a situation of iron overload. We've known for decades that there was tight regulation of iron absorption here at the level of the duodenum, mainly through work actually done by Thomas Bothwell from Wits, with using radioactive iron. That was known as far back as the 40s and then was, as I say, refined in the 60s and 70s. But what actually regulated that absorption at the level of the duodenum remained a mystery until the late 90s when a hormone known as hepcidin was discovered. And in the early 2000s, it became apparent that this chemical or this protein hepcidin, was the master regulator of iron flux, both at the level of absorption at the gut, but also at the level of release from the liver and the other reticular endothelial cells where iron is stored. So how does hepcidin work? We have it here in the slide, sorry. So hepcidin, as I say, controls the flow of iron outside of the cells. It interacts with the protein called ferroportin, which is the only known exporter of iron from cells outside of cells. Ferroportin is found in the lining of the gut in the duodenum. It's also on reticular endothelial cells. And in any situation where iron is required, such as erythropoiesis, probably the most important need for iron, hepcidin acts to basically open up ferroportin and allow iron to flow both from the gut, from the lumen, into the system, and also to release it from the liver where it can become more available. And the opposite holds true in situations of iron overload, where it's critical that more iron doesn't come into the system. Hepcidin is overexpressed, and it basically shuts off that faucet, shuts off that tap that prevents the flux of iron from the gut and from the liver. We recognize that any situation that will lead to increased erythroid demand, such as severe anemia and hypoxia, will dampen down hepcidin. And we also know that iron overload and also inflammation will actually increase hepcidin, sometimes inappropriately, to the point that iron isn't absorbed, even in situations where iron is possibly required. And we may discuss that a little bit later as well. So how do we diagnose iron deficiency? These are the markers or the lab tests that are commonly available to us and that we use. And I think this is just by way of revision. I'm sure anybody who's attending a deep dive in hematology is very familiar with all of these, but I'll just run through them quickly. So microcytosis is certainly not sensitive, and it really implies that this patient has been iron deficient for a long time, to the point that it's actually affecting erythropoiesis. It's also not specific, especially in our population in the Bronx, where we have a lot of Hispanic patients, a lot of African Americans, where thalassemia, both alpha and beta, are common. So a lot of patients will carry these silent hemoglobinopathy traits, resulting in MCVs. If a patient has well-established iron deficiency anemia by other parameters and is not microcytic, you have to consider other etiologies, and certainly folate and B12 would not be unusual to find in these patients. A low serum ferritin, a ferritin below a certain cutoff, what that cutoff is also a question of debate. But for all intents and purposes, a very low serum ferritin is absolutely specific for iron deficiency. A patient with low serum ferritin has inadequate iron supplies, certainly for erythropoiesis. Unfortunately, it's not very sensitive. So implying that a patient with high ferritin, normal or even supernormal ferritin values, certainly may still be iron deficient, because as I think everybody knows, ferritin is an acute inflammatory marker, and in any situation of inflammation, ferritins can go super, super high. Exactly how high they can go in a patient who's iron deficient, I think, is a question of debate, and I would be interested to hear what people say. During COVID, we saw patients with ferritins in the thousands, and certainly within that group, I'm pretty sure that there were patients who were iron deficient. I still need to prove that. But you will hear people say that, under normal conditions, regular type of inflammation that you might see in a patient with diabetes or obesity would not push the ferritin above 100 or above 200, and that anything above
Pretoria Oos, by Pretoria Oos Hospital.
I'm sorry? Was that a question?
Can I just ask everyone to please mute their microphones, please? Thanks. Sorry about that, Mark. Please go on.
No worries. With low-grade inflammation, I think a patient who's iron deficient, their ferritin would not be a go to above 100 or 200. So in those patients, if their ferritin is 300, I think you probably could rule out iron deficiency anemia, but I'm not sure. And as I said, I'd be interested to hear what other people think in that regard. I would say that serum iron and iron saturation are probably the least reliable. I know we rely on a lot, but it's very, very labile. You know, as well, ferritin certainly varies from day to day. We saw that in our patients who were admitted with inflammatory condition, with COVID. You know, their ferritins would change by the thousands from day to day. But I would say that serum iron probably changes by the hour. That's how labile it is. If your serum iron or saturation is low in the morning, and then you have 2 iron pills, your iron saturation is going to be high in the afternoon. So it's useful. We don't typically ask for fasting irons, although we probably should. But we always need to, we always need to interpret it with some caution because of the lability of that. We expect transferrin or total iron buying capacity to be elevated in iron deficiency, but just be aware that patients with pregnancy may not be iron deficient, but they typically have a high transferrin levels. Soluble transferrin receptor is available to us. This is touted as being a test that will differentiate between true iron deficiency and iron deficiency with high ferritins in the presence of inflammation. In true iron deficiency, we expect the transferrin receptor level to be high, whereas if it's low, it will be high even in inflammation with a high ferritin, but when it's low, we can conclude this patient doesn't have iron deficiency. I've really gone out of the habit of ordering because I find that it just doesn't provide me with useful information. You know, I will note that there are a lot of other things. Any situation where you have increased or accelerated erythropoiesis in patients with hemolysis, patients responding to iron, to anemia appropriately, their TIBC, their soluble transferrin receptor concentration will be elevated. So I feel it has poor sensitivity and specificity. There have been multiple attempts to use it in conjunction with a ferritin and various formulas that have been put together to improve its value as a discriminant for iron deficiency with inflammation. I don't know anybody who actually does that, who's calculating logs of transferrin receptor ratios of ferritin. If there's anybody who does, please, I apologize, but certainly I don't find it useful. You know, I think that in clinical practice, often it's the summation of a lot of other data. And the idea of finding one single discriminant that's going to tell you yes or no, I think is somewhat elusive. Once again, I would love to discuss this point. Hepcidin has a lot of promise because, as we said, if patients truly iron deficient, their hepcidin levels should be low. We're not really sure where to use it. It is available for us to order. I've never ordered it because, once again, I'm not sure, you know, how I would use it and what extra information it would provide. Okay. Iron is important for blood, and as much as it pains me to say this as a hematologist, high iron is also important for a lot of other things as well, which leads us to the concept of non-anemic iron deficiency. The idea that patients who have iron deficiency, as defined by whatever, we'll come to that, let's say low iron stores, but are not anemic, that really this might in of itself be a pathological entity. So besides for the creation or the creation of hemoglobin, iron plays a role in lots of other non-hematological places. So myoglobin in all muscle, iron is at the center of myoglobin. In the cytochrome system, multiple reactions are reliant on these cytochromes, which rely on iron. So it's reasonable or logical to assume that a patient who's iron deficient may not have sufficient iron to provide the functionality of all these other places outside of red cells where iron is used. We do recognize various non-hematological associations between iron deficiency, restless leg syndromes, fatigue and cognition, which we'll discuss a little bit later. Patients who are severely iron deficient will experience alopecia, nail changes, and then cardiac function is also proposed to be also a topic in of itself, to be an important, to be reliant on normal iron stores. But the question is this an entity with clinico-pathological significance? So patients who are iron deficient, is this something that we need to identify as a disease that necessarily needs to be treated. Dr. Howard James, late of the Manhattan State Hospital, probably around at the turn of the century, certainly thought so. So at this time, iron was really proposed as an elixir for everything, causing men to become vigorous, iron men, and beautiful, healthy, rosy-cheeked women. So certainly there's a lot of anecdotal reason to think that iron could help with a lot of other things besides anemia. And if you don't believe Dr. Howard James, late of the Manhattan State Hospital of New York, maybe you'll believe the Pope. The Pope even gave an endorsement, or maybe not the Pope, but certainly the pharmacist of the Vatican has also endorsed iron as being kind of a panacea for multiple issues. For the rest of us non-Catholics, maybe that's not sufficient. So we want to see what is the evidence that actually there is this entity of iron deficiency causing morbidity, independent of anemia. And if so, what is the evidence that actually doing something about it makes a difference? So we've had various trials that actually prove precisely this point. The first one that I can find was from 1960, which was a trial of oral iron, looking at fatigue, and showed a difference. It wasn't a particularly well-conducted trial, but since then we've had multiple prospective trials that have looked at interventions. Some of these trials are better than others, but these are two trials that I've, from relatively recent times, that have looked particularly at fatigue, where we seem to see the best effects, so to speak. And this is a population of menstruating females who are not anemic, with high fatigue scores, who by definition had anemia, had iron deficiency. The ferritin cutoff was 50. They were prescribed oral iron versus placebo. And at various time points, the fatigue scores were shown to improve on those patients who took oral iron. Here's a similar trial. This trial was done with injectafor or ferrin injectors, I think you call it, iron carboxymaltose. This was an intravenous trial, also with a similar population of iron deficient non-anemic women. Here they looked at various parameters, and there was some benefits, statistically significant in various fatigue parameters. These are all done by questionnaires, certainly. Alertness, contentment, and calmness. So it seems good. On the other hand, these are two more recent trials. I've included some diagrams from the second of those trials from 2022. These were two trials that were done at probably our ideal model iron deficient population, which is blood donors. If you want to do any studies in iron deficient patients, the blood donor population is a great cohort. They're great patients and they're great trial subjects. In both of these trials, patients who are identified, or individuals who are identified as being iron deficient, not hard to find in a cohort of blood donors, were treated either with placebo or intravenous iron. They were looking particularly at effects on cognition. And this follows on several other studies, including the ones that I just showed you, that did show that there was some benefit in cognitive abilities in patients with iron deficiency who were treated with intravenous iron. In both of these trials, well, first of all, this is the second trial that was done. First of all, where they looked at some of the parameters to kind of quantify or qualify the nature of the iron deficiency in these patients. And they look at, a lot of the things that we typically will look at. I think at the top was hemoglobin and ferritin, or ferritin is down here. But these are the two populations at the time that they were screened, and then at the time that they were randomized, when they were after they donated blood, they were then randomized. One half of the population was treated with intravenous iron, the other wasn't, and then they looked at various of the parameters. So in all of the iron-related parameters that we typically look at, they saw the expected results. So here you can see the difference in soluble transferrin receptors. So yes, certainly the patients in the placebo group, their STFRs were higher, they were less iron deficient. Obviously, their ferritins were lower, et cetera, et cetera. But when it came to actually looking at the outcomes, there was no statistical significance. So there was no difference at all. These patients underwent a battery of cognitive tests, and virtually every single one of the cognitive tests that these patients or individuals were subjected to showed no difference. So, I don't think this negates all the other work looking at the benefit of treating non-anemic iron deficient patients for cognition, but it certainly raises some questions. One can hypothesize that maybe there's something different about the blood donor population and iron deficiency from blood donation compared to the more usual cause of iron deficiency out there, which is heavy menstrual bleeding in females. But it certainly raises some cause for some reflection about the universal role, so to speak, of treating patients with non-anemic iron deficiency. This is just a summary slide of some of the questions that I have. Where we've seen a different, are these effects really independent of hemoglobin? Often these patients, even if they're by definition not anemic, their hemoglobin typically goes up to some extent, and maybe we're just seeing the difference as a result of higher hemoglobins, even though they weren't anemic before and after, but still within the non-anemic range. The parameters that we're using to define iron deficiency, maybe we should be looking at some other parameters. Maybe there are other parameters that are more useful in predicting who will have a good clinical response to iron supplementation. So some food for thought. Okay. All right. At this juncture, a basic question. What are we even talking about when we're talking about iron deficiency? So I think anybody can say that, yes, well, if a patient has a bone marrow biopsy and you look at the bone marrow and there's no iron there, that patient is iron deficient. Certainly, we're not going to be doing bone marrow biopsies, although I think Professor Perspoda, when I was a medical student, that was his modus operandi, to do bone marrow biopsies to diagnose iron deficiency. But, as clinicians, we need to have a better concept of what we mean by iron deficiency and, what are the goals of saying that a patient is iron deficient? What do we want to get out of it? And, how is it going to help patients? There's different ways of defining iron deficiency. So as for any other lab value, we first of all take a statistical approach looking at the important marker of iron status, which is ferritin. We look at standard deviations, and anybody who's below 3 standard deviations in what we call a normal population is by definition iron deficient. Clearly, this is not a great definition. It really depends on the population that you're looking at. And certainly, there'll be a lot of patients in any population who what would call a normal population who certainly will be iron deficient, even with values that are higher than that 3 standard deviation cutoff. There's a physiological concept of iron deficiency that perhaps it's got nothing to do with the parameters that we're measuring, possibly not ferritin, but perhaps there's another way that we can measure the effects of insufficient iron in terms of tissue delivery. And I don't think we're anywhere with that, but that would be the ideal if there was some other parameter that would say that, yes, this patient who is experiencing fatigue, we're measuring the serum blah, 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 which is a reflection of low iron stores, and that is directly correlates with the fatigue that they're experiencing. That's somewhat idealistic. We're not there yet. And then there's a concept of functional iron deficiency, which I think most people are aware of, and this ties back into the idea of anemia of inflammation or the anemia of chronic disease, where patients are not iron deficient. If you do a bone marrow biopsy on these patients, there's plenty of iron. If you look at their liver, there's plenty of iron. But these patients are anemic, and they have other stigmata or other effects downstream of iron deficiency because of a question of delivery of iron. And, you know, our understanding of anemia of chronic disease in 2024 is that this is a function of high hepcidin levels, that even though the anemia or the iron is available, there's no shortage of iron, it's just not getting to where it needs to. It's sequestered in reticular endothelial and Kupffer cells, and it's basically just not getting to where it needs to get to. And whether that's the developing erythron or other tissues where iron might be required. The last way of talking about iron deficiency is the utilitarian way. And if you've never heard of it, I don't blame you. And that's because I just made it up this morning when I was thinking about giving this lecture. What do I mean by the utilitarian? So I'm a clinician, as I've mentioned before, and I'll propose to you that iron deficiency is any condition in which we give iron supplementation, something gets better. So a patient with iron deficiency anemia, the hemoglobin is 8, you give them 1,000 milligrams of iron, they come back 4 weeks later, the hemoglobin is 12. Clearly that patient has iron deficiency. Patient who complains of chronic fatigue, their hemoglobin is 13, their ferritin is 12, you give them 1,000 milligrams or 500 milligrams of iron, they come back 3 weeks later and they tell you, I feel great, I feel wonderful. That patient has iron deficiency. We don't have any good predictors, but as somebody who has access to an intravenous iron infusion suite, I have the best tool for diagnosing utilitarian iron deficiency, and that's a trial of therapy. So if there's any situation where I'm not sure whether this patient will benefit from iron, or stated otherwise, I'm not sure whether this patient has iron deficiency, I give them 500 milligrams of iron dextran, and they come back 3 weeks later, and they either feel better or they don't. They either tell me they feel just as tired or they feel better. If they feel better, I'll say, yes, you had iron deficiency by definition. I know it's not the most scientific definition, but it's a working definition. And once again, I can't wait to have a discussion to hear what people think about this approach. Okay, I think that concludes my discussion or general discussion on some concepts of iron deficiency and iron deficiency. I'm going to talk a bit about oh, sorry, I thought these slides were out of sync, but this is on the concept of non-anemic iron deficiency. I'm just going to do a little segue and talk about non-anemic iron deficiency in pregnancy. You know, it's clear that anemia is not good in pregnancy. It's linked to, you know, a multitude of adverse maternal and fetal neonatal outcomes. What's not so clear is the situation of patients who are not anemic in pregnancy but have low ferritin. And of late, there's been a ton of discussion about this population of pregnant patients and kind of this frenzy, this implication, alarmist that we're not managing these patients or that we're underserving these patients by not, first of all, screening for iron deficiency in this population and not treating them. And the cause for concern is clear, right? We know that neonates who are iron deficient have impaired developmental brain development. So we certainly don't want to take any chances when it comes to subjecting neonates to iron deficiency and the risk of cognitive or adverse neurological outcomes. Because we know that neonates with low iron are impaired, does this imply that the mother who is iron deficient, that the neonates or the fetus will similarly also be iron deficient? Because if that's the case, then that certainly is of a concern. So asking the question otherwise, is there a correlation between the status of the iron status in mothers versus the iron status in neonates or in developing embryons and fetuses? This is a paper that's often cited to prove or to demonstrate this correlation, where they looked at thousands of Chinese women with where they measured the ferritin, maternal ferritin and cord blood ferritin, which is a measure of neonatal ferritin. And I mean, to me, this looks like the plots are all over the place, but statistically, there is some correlation that was shown that below a certain level, below a maternal ferritin of 13.6, there is a correlation. So that women with ferritins in this range, the lower the ferritin goes, the lower the cord ferritin, implying that there is a risk to the developing fetus. A more recent review looked at all of these studies and came to the conclusion that they didn't believe that there was such a correlation. And the implication was that if there's no real, implication to the fetus, then there's no point in even screening mothers. And in fact, this is the recommendation of, well, we'll come to the guidelines. So this is the concern. This is what we know, and this is what we don't know. These relations are well established. So we know that women who are iron deficient, when they become pregnant, they'll be iron deficient in pregnancy. We know that iron deficiency in pregnancy can lead to anemia in pregnancy with both maternal and neonatal adverse outcomes. We also know that in animal models where pregnant animals were made severely iron deficient, there were adverse outcomes to the neonatal animals. We know that fetal or neonatal iron deficiency, where it occurs, has also all sorts of adverse outcomes. Where the link is a little bit more tenuous, you can see I didn't shade these arrows in bold red as I did with the others, where there is a correlation between fetal neonatal iron deficiency and maternal iron deficiency. And the real question, which we don't have good evidence for, is once again whether iron deficiency in pregnancy implies that the infant, the neonate, will be at risk of all of these very worrying neurological outcomes. Personally, I don't know. I think one should always err on the side of caution, especially when we're talking about the brains of children. But I think, and once again, I would like to hear if anybody has any other thoughts. I think the evidence that iron deficiency in pregnancy affects neonates and neurological outcomes, I think that evidence is missing. It doesn't mean it doesn't happen, but I don't think we have good evidence that that actually occurs. This is reflected in most of the guidelines, which don't actually advise for screening in pregnancy, screening with ferritins, but just looking at CBCs or FBCs and just looking at the hemoglobin to determine whether an intervention should be made. Okay. Time is creeping on. Treatment of iron deficiency. So oral iron is the first line therapy. There's tons of different types of oral iron. Ferrous sulfate is still the most commonly used. It's poorly tolerated by all standards. Some reviews will say that 70% of patients who take oral iron will have adverse effects with an adherence rate of 30%. I don't believe it's that high, but this is what we're led to believe. In terms of which iron is best, so every time I give this talk, people will tell me about this iron or that iron. I don't know which iron is the best. I think the most important thing is to make sure that in any patient you're treating with oral iron is that you're giving the right amount of milligrams. Very often a patient will tell me, I'm trying this iron, nature's blah, 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 and I have no side effects at all. And, when you look at the package insert, you see that's because that each pill, maybe has 3 milligrams of iron. So it's really a function of how much iron there is. So one has to be cautious about the amount of iron in any formulation. The only rigorous trial really that I've seen that compared two iron formulations was this one, actually in pediatric patients, where they compared iron sulfate to iron polysaccharide, which was very popular, Niforex, and people swore by it. They said, oh, so much better. In fact, there wasn't any difference at all, both in adverse effects and certainly not even in response. Patients who were given ferrous sulfate actually did better. Any discussion of oral iron has to talk about this, the alternate day recommendation. this paper came out in 2015, and it basically looked at the absorption of iron depending on the timing of it. And what they clearly showed was that if you took an iron pill and then you took your second iron pill either in the afternoon or the same day or even the next day, the absorption of subsequent doses was impaired. You didn't absorb as much. And it was only by the second day that absorption went back to its prior levels. And they very elegantly showed that this related to hepcidin levels. After an oral iron load, your hepcidin levels go up. When hepcidin levels are up, you don't absorb iron. And it was only by day 2 that hepcidin levels dropped back to their baseline. This led to this recommendation in UpToDate. I don't know how popular UpToDate is. American physicians swear by UpToDate. Basically saying that, yes, when you start patients on oral iron, you should give it every other day. It was somewhat of a premature recommendation because, you know, this was not a clinical study treating patients with iron deficiency. This was basically just a proof of principle. You know, the other obvious conclusion was that if you're treating a patient with iron deficiency, they have taking one pill every day for 30 days, and you change that to one pill every other day, you're effectively decreasing the iron that they're taking by 50%. So even if you're improving their absorption of each pill by 30%, the net gain doesn't actually make up for it. So I think UpToDate had subsequently dropped this recommendation. Even before this, there were several trials that looked at intermittent dosing, and none of them were positive. And the practice has never really become widespread until recently. Subsequent to the hepcidin study, there have been a few clinical trials, not great trials, that have looked at daily versus alternate day oral iron, and they've been mixed. I think what they consistently show is that patients who are on daily will probably not tolerate the iron as well, but certainly if they do tolerate it, they will attain a higher hemoglobin at a quicker rate than if they're taking it every other day. And I think that's obvious. I don't think anybody would have expected otherwise. This is another one of the trials that really didn't show much difference. These are the guidelines that I give as part of our institution. I think a patient who is iron deficient, who is going to be started on oral iron, should start with iron sulfate. I say start 1 a day. If you can take 2 a day, great, but don't split the doses. Take 2 in the morning. If you're not tolerating well, you can take it every other day, and you probably won't lose that much, because what you're losing in terms of how much iron you're taking, you're making up in terms of better absorption. Okay. Certainly oral iron isn't for everybody, and there are patients who will not absorb oral iron at all. Particularly our bariatric surgery patients. So these patients, you know, will have impaired iron absorption, and no amount of oral iron, even if they do tolerate it, will alleviate their anemia. So intravenous iron, which we've been doing for 100 years probably, has really taken off probably in the last 2 decades. We have multiple preparations available. This is what's available in the United States. We actually have one more, which I haven't put in this table. Iron gluconate and iron sucrose are limited by the amount of iron that you can give in one infusion. Venofer or iron sucrose can be given at a maximum of 200 milligrams. The average patient who requires therapy for their iron deficient will need typically more than that, which implies the need for multiple infusions. So iron dextran, which has been around forever, and newer formulations like iron carboxymaltose and ferromoxetol allow for what we call total dose infusion, which typically means that a patient's entire calculated or estimated iron deficit can be addressed with 1 infusion or 2 infusions at most. You know, and I think it's really insane to bring a patient back 5 or 8 times, which we were doing with Venofer when you can get the same thing done with an hour or 2-hour infusion. This is iron use. It's a big business. Lots of money involved. This is the world markets in 2021, 1.2 billion. Sorry, this is just the United States. And certainly driven by pharmaceutical companies that make these products, you know, have influenced us as clinicians, and maybe rightly so, because it is a very quick and effective way of treating iron deficiency. And this is worldwide, similar trends, $2.2 billion in 2020. Okay, and I'm going to try and finish off with a little bit about what we're doing, or what I'm doing at Einstein, which is facilitating a way to get patients who require IV iron in a quicker and more efficient time. So first of all, as a hematologist, I don't typically see these patients. Most patients will be managed by their gynecologists or their obstetricians or their primary care physicians, who will diagnose oral iron deficient and start them on oral iron. And many times they will be on oral iron for many years. And even though the oral iron is not working, for various reasons, these patients are not being referred for intravenous iron. There are a lot of misconceptions about the safety of IV iron, misconceptions about the intensity of the therapy, and also probably some complacency about iron deficiency in general, and also about the toxicity of oral iron. And probably most important, which we want to address, was the lack of access to infusion facilities. If you're a primary care physician somewhere out there, you know, you may not really have certainly you wouldn't have the ability to give IV iron. It requires referral to a hematologist and everything that evolved. So what we wanted to do, based on these following two assumptions, we wanted to, first of all, make it known that IV iron is safe and beneficial for appropriately screened patients. And also, the other assumption was that screening patients and identifying who is appropriate for IV iron doesn't need a hematology evaluation, that evaluation can easily be done just by reviewing some basic data. So the CBC, or the full blood count, their iron studies, and just the clinical context. And this was launched in 2020, in the middle of the COVID epidemic, where we weren't seeing patients. And we thought that using our electronic medical record, and also using the e-consult platform, which had been developed, which basically allowed us to chart review and answer clinical questions without seeing patients, we could build a referral system that allowed us for patients to be referred to us electronically, for us as hematologists to review the situation, determine whether a patient was a candidate, and set it up. So we went from this situation, which was the historical workflow, which could take anything from 3 to 4 months, to this situation, where any patient who a referring physician thinks needs intravenous iron, they place we call it e-iron consult in the medical records. Within 3 business days, the hematologist reviews it, determines their eligibility. If they're determined to require intravenous iron, that gets scheduled. And within 10 business days, the iron infusion actually occurs. This is what the interface looks like. So this is the EPIC EMR, which is very widespread in the United States, probably the most popular EMR. This is all protocol template driven. Physicians will basically just enter the information that they're asked. So for example, on this screen over here, this is a referral for iron deficiency in pregnancy. We ask that they inform us when is the date of delivery. Certainly the iron studies need to be included. And we make it happen based on this information. We reported this in 2020, our first 3 months. And this basically showed that it worked. So basically that the patients were being scheduled, and that the infusions were being scheduled within 2 weeks of the request. And that was happening pretty quickly. What we didn't really know until afterwards was whether first of all, whether the infusions were actually occurring. And secondly, what were the outcomes? The biggest criticism that I got at the time was that, we as hematologists manage these patients. We infuse them, we bring them back, we make sure that their hemoglobin is good. And more importantly, we address what's the cause of the iron deficiency. So it wasn't a big concern of mine, I must be honest, because I know iron infusion works. If a patient is anemic and you're pretty sure that they're anemic from iron deficiency and you give them iron, if you bring them back, 2 months later, their hemoglobin should be normal. So we did a chart review, basically to looking at these patients who, for the vast majority, we had no contact with, to see whether we were actually achieving what we wanted to achieve. And this is just a breakdown of 18 months, 477 patients were referred to us. This is the context. About a third were pregnant patients. About a half of the patients were women with heavy menstrual bleeding, and then a variety of others. We were happy to see that of the patients who were actually scheduled for infusion, 90% in fact did get the infusions. And we also wanted to see if the cause of the iron deficiency was being addressed by the primary care physician. So we looked at the charts and we saw that in about 85% that the primary care physician or whoever was referring the patient was actually following up on that. And these were the hemoglobins. We looked at the highest and the lowest hemoglobin, the first one after the consult and then for the following year. And we saw that there was a significant improvement, and certainly the improvement was higher in the patients who were approved for intravenous iron. In patients who were not approved, it was typically because it wasn't from iron deficiency or because the anemia was more complicated. And in those patients, we wanted a face-to-face evaluation. We did another study last year where we looked specifically at patients referred for pregnancy. And this was over a year and a half. 239 pregnant patients were referred. The majority of the referrals happened late in the third trimester. And about 2/3 of the patients, and this actually goes across the board, of patients who are referred to e-iron, about 2/3 are approved for intravenous iron. Once again, about 90% received the infusion, which happened about 13 days after, which is incredibly fast. I don't know how it works at other big institutions, but certainly at our institution, you can't get an appointment with the hematology for 3 months. So, if you have a woman in her third trimester who needs intravenous iron, referral by the traditional route is basically a non-starter. So we were happy about that. When iron wasn't administered in that 10%, it was either because the patient didn't show up for the appointment or because they delivered prior to them actually showing up for the appointment. Most of the infusions were single dose. We had a high proportion of patients who had bariatric surgery. Where intravenous iron was not approved, it was because it was deemed to be without utility. And that's typically because the referral came maybe a week or at most 2 weeks before the expected date. So we didn't see any utility in giving those patients intravenous iron. Certainly it wouldn't affect their hemoglobin significantly by the time of delivery. One could argue that it would certainly help with their post-delivery hemoglobin recovery. But we said if that's the case and they lose a lot of blood during the delivery, then give intravenous iron when they're admitted. And that was actually done by the obstetrics department. This is the results of the hemoglobins. And it's a little bit much to look, but I guess I'll just draw your attention to this line over here. The average hemoglobin at the time of referral was 9.2. And at the time that they presented for delivery, the average hemoglobin was 10.44, and significant decrease in the proportion of patients who were anemic. We also looked at the hemoglobins were available in the postpartum, and that improved. So patients who were infused, actually everybody, in the postpartum, their hemoglobins were continued to improve. Just two other interesting things we showed. This was quite obvious, but it was quite nice to show, was that obviously the sooner you refer the patient, the more the increase or the better the increase in hemoglobin. So patients who who were referred less than two weeks, a minority of these, but certainly the change in hemoglobin was minimal compared to those who were referred more than 6 weeks, where we had a significant change in hemoglobin. We wanted to show that this proactive approach in early infusion of iron in anemic pregnant patients would decrease transfusion rates. Unfortunately, we did not show this. What we were kind of surprised about was that in this cohort, transfusion rates were high. So the cohort was 221 patients, of which 27, so that's, close to 10% of patients, more than 10% of patients in this cohort required transfusion. The patients who required transfusion, basically it was because of postpartum hemorrhage. When we look at those who got transfusion and didn't, they were both presenting with more or less the same hemoglobin. So the iron was doing its job, but for some reason, within the cohort, a good proportion, 27, had an estimated blood loss of, over a liter, requiring transfusion. Why we had such a high rates of transfusion, we're not actually sure. We had proposed that maybe this was just a high-risk cohort and that the obstetricians who were using e-iron were maybe more on the ball and more concerned about these patients. But when we looked at other scores that looked at propensity to postpartum hemorrhage compared to others, this actually turned out not to be a high-risk group. The other suggestion was made that maybe the fact that these patients who are presenting with iron deficiency in pregnancy, certainly you don't become iron deficient. When a woman becomes iron deficient in pregnancy, it's because they were iron deficient before their pregnancy. So is it possible that these patients had some type of bleeding diathesis? Was there a higher rate of von Willebrand's disease in these patients? And that's why they were part of the cohort, because they were iron deficient before their pregnancy, they were iron deficient during the pregnancy, and they were more at risk of having postpartum hemorrhage. I don't know if that's true. We're going to look at it, but if anybody has any good ideas, I'd be happy to hear them. I see that I've used up my hour, and I'm happy to stop there. Vernon?
Mark, you can continue a little bit longer. I think if we can start question time about 10 past, that would be great.
Okay, all right. So that'll get me through the rest of my slides. All right, so that's what we've done now. I just want to give a little bit of an overview of what I'm currently busy with. And I'm going to start with a little case vignette of a somewhat typical patient that's referred to e-iron. This is, I don't know if you can actually see it, but this is the curves of their hemoglobins and their MCVs. So if you look at the timeline, this is 2014, 2017. So from 2017 until their referral in 2023, their hemoglobin has gone from normal to, that is, I'm struggling to see myself, to a hemoglobin of a 7 or 8. Okay. If there's any doubt in your mind of what's causing that anemia, I mean, I think it's pretty clear. There's only one thing that causes a change in MCV and makes a patient microcytic. It's iron deficient. So, what was going on during this time? Certainly the patient was being followed. They were having multiple full blood counts that were being done. Why am I only getting this referral now at this point in 2023? The patient was having iron studies done, and sure enough, this is 2011. Already by 2017, we have a ferritin of 11. Okay, so that's six years prior. Nothing was happening. Patient gets referred to me. I look in the chart and I see, clearly this is a 47-year-old female. I would presume that she's having heavy menstrual bleeding. And if she isn't, somebody should at least ask her. We can search with terms through the entire medical record. And, I pick up that she had bariatric surgery in 2016. She was prescribed some iron. Over the years, she was prescribed iron sulfate, iron gluconate. I looked to see if anybody has taken a gynecological history, and this is literally all I could find. She has an IUD in place, satisfied, having regular menses, no blah, blah, blah. In September of 2022, she's not taking iron because of constipation. I strongly advised iron and will add Miralax. We'll also check TSH. Additionally, discuss self-care, filling her own well. I don't even know what that means, but clearly that's not addressing this iron deficiency. When I respond to these e-iron requests, in addition to approving intravenous iron, I will also try and provide some guidance. So in such a case, I will also, include some, and this is boilerplate stuff that I will include, some recommendations, particularly, in a woman who we expect that the etiology of her anemia is heavy menstrual bleeding, that, somebody actually takes a look at it. So these are some of the comments that I'll put. The importance of gynecological is emphasized. Screening and addressing heavy menstrual bleeding is the first priority. I can't even tell you how many times a woman of 47 with heavy menstrual bleeding gets sent to the gastroenterologist as the first step to address their iron deficiency anemia. I don't even know. And then becoming more and more passive aggressive, especially when patients are referred to me multiple times and nobody's taking care of their gynecological problems. PRN IV iron with this frequency is not an acceptable or sustainable management strategy for heavy menstrual bleeding. Anyway, I don't typically write that, but that's sometimes what I have to do. So, it becomes clear to me that in this population, iron deficiency anemia is not so much a hematological disease. This is a woman's health issue. It's very easy for me to treat the iron deficiency anemia, but unless the underlying issue is taken care of, the patients are going to recur. It's just going to come straight back. And the analogy I always give, somewhat crude, to patients is if you don't take care of this, you have a bucket with a hole in it. It's easy for me to fill the bucket, but unless someone takes care of that hole, you're just going to be back. There's an underappreciation of the prevalence of iron deficiency in this population. There's an underappreciation of the morbidity associated with iron deficiency, the prevalence of heavy menstrual bleeding. There's an underappreciation of the nexus between heavy menstrual bleeding and iron deficiency anemia, and then just a general undertreatment of heavy menstrual bleeding. This review paper came out, I highly recommend it, which basically shows this, this interlinking between these two areas, that they're, really very close and locked together. On the hematological side, the iron deficiency and iron deficiency anemia, but on the gynecological side, and unless both are addressed, you're only doing half the job. Looking at our own data, when we focused in with a chart review on 42 patients who were referred with heavy menstrual bleeding, and we looked at the lowest hemoglobin in the year after the referral, of 36 patients who were treated with intravenous iron, recurrence rates were high. So if we considered anemia as a hemoglobin less than 11, 40% of patients actually recurred within the year after infusion, which, really drew to our attention the fact that that this is an issue that needs to be addressed, and certainly that e-iron, which is a completely hands-off strategy for managing patients with iron deficiency, is not going to cut it. It's not, a holistic approach to taking care of these patients. So with that in mind, we are pioneering the hematogynecology clinic, and which is, I'll read this, it's a multidisciplinary intervention aimed at women referred for intravenous iron via the e-iron platforms with severe anemia caused by heavy menstrual bleeding, ensuring they receive appropriate post-infusion follow-up with gynecology to prevent recurrence. That's basically a fancy way of saying is that after patients who are screened and noted to be having iron deficiency anemia from heavy menstrual bleeding, we are making sure that they follow up with gynecology, and we are arranging expedited, fast track follow-up with gynecology. This is the algorithm which we actually just set up last week. We propose that it will work in this way. A patient who's referred to intravenous iron, who we consider that heavy menstrual bleeding may be a possible etiology of anemia, and that's easy. That's any woman between the age of 18 to 50, or 55, let's say. They're eligible for screening. At the time that they arrive for their infusion, the infusion nurses will administer a questionnaire, which we have modeled for them, and determine which of the following categories. Either the patient has normal menstrual bleeding, in which case they receive their infusion and they're off, no follow-up. In any of the other categories where they have ongoing menstrual bleeding, we set up, first of all, we educate the patient. It's quite astounding how often patients arrive at the infusion units knowing they need intravenous iron, but have no idea how they came to be iron deficient. When they'll give a history to the infusion nurses and say, I have to change my pad like 12 times a day, or I'm wearing diapers in some cases, but have no idea that that's actually linked to their iron deficiency anemia. So any patient who's having ongoing heavy menstrual bleeding gets a follow-up appointment where we check their FBC and just to make sure that they've responded, and they will respond. But if their FBC, if their hemoglobin isn't what we predicted to be, that's an indication that they're still bleeding and that there's been bleeding in the interim, and a menstrual history to ensure that their GYN needs are being addressed. Some patients are already under the care of a GYN. We basically just educate them, make sure that they follow up with a GYN. And then a significant proportion of patients actually cannot get access to GYN. Certainly in our system, once again, it's very difficult. You wait ages to get access to GYN. We can, through this system, we are arranging them a follow-up with a GYN who specializes in heavy menstrual bleeding within 2 weeks. We call this the expedited GYN appointment. And then once again, a follow-up. And that's all I have to say. So I think I've covered a lot, and I touched on a lot of points, and I would very much welcome comments, discussion, and questions.
Mark, thank you so much for that comprehensive overview. I think if you were in any way concerned that there would be discussion and or questions, you can just look in the chat box.
Oh, I didn't notice.
I think we will have to do this at high speed. But yeah, first, thank you so much. I think you've also, apart from just reminding everyone about the importance of iron deficiency everywhere, you've also raised some important points about some areas of dispute, perhaps some controversy. And if there's time at the end, maybe I can also make some comments on how I see certain of these points. But let's give opportunity to those who've asked questions in the chat first. Okay. So yeah, I think there was
should I just read through them? I can see them here.
Okay, you can go
that way. Okay.
Comment on them as you go along.
All right. So Vernon agrees fasting iron is important. Do you do that?
Yes, I do. If it's complete iron studies, not if I do a ferritin screening, but the moment you do transferrin saturation, because your serum iron is affected by morning, whatever you had in the morning, especially patients are on iron supplements and you're trying to monitor them, you're going to have an abnormal value. And if you look at the guidance in the laboratory testing thing, you're supposed to actually do that transferrin saturation faster.
Makes absolute sense. Jennifer Corin Hall says, we used to look at serum iron to see if patient had taken our tablet in the morning, only use. I agree. And we used to do an oral iron absorption test. And this was the basis of the oral iron absorption test. Does anyone use reticulocyte hemoglobin? Yes, I'm sure somebody uses it. I don't. There are a number of these parameters that are available. They're generally proprietary to the automated cell counters that come out, and I think Sysmex has one, and there are various parameters which look at the incorporation of hemoglobin in reticulocytes. And certainly a patient who's responding to iron, you would expect to see that go up. I have to be honest, I haven't really come up with a good use for it. I know that, within my division, somebody was agitating that we should include it in CBC, and the lab agreed. And now in our full blood counts, we do get one of these parameters. I can't remember which one it is. And, when I polled my colleagues recently, I said, does anybody actually use it? They said, no, we don't. Yeah, I'm sure people use it. you know, I don't think it provides, me personally, it doesn't provide any information that I can't get from, well, I'm not getting from the other parameters.
I make a quick comment, Mark.
Sure.
So I think the confusion there comes with, there was an article in Blood where it was proposed to use this as a way of diagnosing iron deficiency when you've got dubious results. But I think I was not too happy with that particular article. I think the value is more to exclude iron deficiency in the context of inflammation. And I think the context within which this was shown was oncology patients, which is often the type of patients we see as hematologists, that if the reticulocyte hemoglobin is normal, and you've got a low SATs, low transferrin SATs, and a normal or highish ferritin, then it's unlikely for the patient to have iron deficiency in conjunction with the iron, with the anemia of inflammation or anemia of chronic disease. But that said, we're doing a couple of studies now to look at reticulocyte hemoglobin and its use, and I have certainly become less enthusiastic about it than what I was earlier. So I think I'm moving to your position. I'm still using it and trying to figure out how to use it, but I don't think it's as great as we thought in the beginning.
Okay. All right. Yeah, I'll look out for that. I think I can't imagine. Yeah. The CHR is especially useful when compared to the MCH or the CHM. I don't know what CHM is. Fair enough. Microcytic anemia that responds to iron. I'm not sure. Is that a question?
I suspect that comment was made during the time when you said, I think when you talked about your utilitarian approach, patient, that how you define iron deficiency in retrospect. I guess that
Okay.
might be it. But I see Jennifer has got her hand up. I don't know if she wants to comment.
I'd love to hear a question. Jennifer?
Can
you hear me now? Can you hear me?
Very softly, very softly.
Oh, we struggle to hear you, Jennifer. I think there's...
Okay. Now can you hear me?
That's better.
Okay. The one comment with that CHR, we found that if the CHR responds very fast, faster than the other things. And if you look at it compared to the CHM on the Advia counters, if the CHR is lower than the CHM or the MCH, it's almost definitely iron deficiency. And the other cause of iron deficiency, especially in pregnancy, we cannot do iron studies on all of them. And if they've got a microcytic anemia that's responding to iron, that's where I agree with him, with his doing this, where you give the people iron and see what happens. It actually is almost definitely an iron deficiency anemia. That's why I put it there as microcytic anemia. One of my biggest problems in pregnancy is that they keep on giving iron combined with calcium and other things that block its absorption. And you've got me now yapping, you're going to be sorry. The other thing we found in the anemia clinic, which I started long ago, as I told you in 1988, was if we gave them iron on an empty stomach, the patients would puke. So I started giving iron in the middle of the meal 3 times a day. And whatever happened, it responds very beautifully. So that's my only comments. Thank you so much for the talk. I really enjoyed it.
Thank you for those comments. And yes, I would actually say that I think that is an interesting area is pregnant women. You know, if you're not checking iron studies and not checking ferritin, if we can find a red cell parameter, whatever it is, that can be predictive of who will develop iron deficiency anemia, I think that's potentially a very useful area to look at these parameters. How labile is labile with reflecting on a patient or recent, it's still first time ferritin. Yeah, I'm not sure how to answer it. It's very labile. How labile, I'm not sure. You know, it certainly goes from the low range to the normal or supernormal range, and very often we'll see patients with saturations above 100%. You know, you can be sure that those patients had recently had an iron load. On the topic of transferrin saturation, a patient with confirmed iron deficiency had a course of Venofer. The ferritin went from 2 to 148. 4 weeks later, the transferrin sats remained 10%. Normal CRP ESR. How would this be explained? If the patient was very, very anemic, then that makes perfect sense. So basically what you've done is you've, replaced their iron stores. But if you check their ferritin, if you check anybody's ferritin straight after infusion, the ferritin will be sky high. And that's just reflective of all the iron that's stored in the liver or in the reticular endothelial system. But that is slowly being provided to transferrin, and that transferrin is providing it to erythropoiesis or to the developing erythron. So it's literally going to, not literally, it's going to suck off that iron. So I think that's more a reflection of very avid utilization of circulating iron, which explains that low saturation. I mean, yeah, so that's a good case. I certainly wouldn't consider that patient iron deficient, in the absence of inflammation and a high ferritin. It's probably just hasn't reached a steady state yet.
Mark, I think this is an important point, if I may just add quickly. So whenever you give a patient intravenous iron, you have to wait at least 4, but often 6 weeks for a new baseline ferritin to occur. After dose of intravenous iron, the ferritin often goes up to 800 after 3-4 weeks, and then slowly returns to a new baseline. So you could have a falsely raised ferritin as well. Now the package insert usually says 4 weeks, but if you look at some of the data from the studies, many patients take 6 weeks for the new baseline to be achieved. So I would be interested in this case to see what the ferritin will be a little bit later on.
Yeah. Okay. What about sucrosomial iron? Stated to have a better side effect profile. Yeah, that's a great question. Yeah. Some time back, I spent a lot of time talking to the company in Italy that makes this formulation, and they had all sorts of extravagant claims. One of their claims was that their absorption of iron was hepcidin independent, which, if they could prove that, would be revolutionary. But there's a lot of pseudoscience there. There are no good rigorous trials that shows that this particular formulation is better tolerated. They've never done a head-to-head with any other iron formulation. But I don't know, patients like it, and I know that it's very popular in South Africa because I know when my mother was iron deficient, her surgeon or the gastroenterologist said, there's only one iron for you, sucrosomial iron. But, there's anecdotal experience, which may be good. I've never seen any good. I don't know, Vernon, whether you are aware of this formulation or whether you've had any experience with it.
I think there are definitely questions that I've also recently raised with the company about some of the data, and I've asked them to send us better quality data to understand exactly what the details with regards to their studies are. There's a lot of stuff in abstract format, even head-to-head stuff, but in abstract format that makes it difficult to interpret.
Yeah, don't hold your breath.
There was a big review by a group in Spain that looked at this that appeared positive. I think just to remember, sucrosomial iron in South Africa is registered as a supplement. So in other words, if you look at the dosing, 1 tablet a day is purely a supplementary dose. So theoretically, you should actually have more than 1 tablet a day if you want to get an effect. I think from my personal experience, it is generally well tolerated, but the responses are variable. Might be sometimes good, sometimes less so. So I have seen responses, definitely seen, I think, generally reasonable tolerance. But yeah, look carefully at the dosing as well, and I think we need some more data on that.
Yeah, I agree. And it's not going to come because I don't think they have any interest in, I told them, I said, if you do a head-to-head and you can show that it's better than iron sulfates, but they're not interested. Jennifer, like the rule of a max of 20 milligrams per kilogram in a single dose, we use this in the next dose the next day. Would you try the utilitarian approach in the patient with possible iron deficiency with inflammation? Yes, absolutely. This seems to me a basic question, but I don't think anybody has ever really asked this. So what happens if you give a patient with anemia of chronic disease? It's not necessarily iron deficient quantitatively, but by giving them extra iron, are you able to kind of overcome that mobilization problem? And if you ask different hematologists, experts in the field, you'll hear different answers. And I don't even know what the answer to this is. And I think the question is very subtle, or it's very nuanced, and it really depends on the context. But if there's any situation where I'm not sure, I mean, there's certainly situations where a patient is clearly inflamed. Their hemoglobin is as you would expect it to be, say, with a patient with whatever condition. But in the more nuanced, some of our cancer patients, if I'm not sure, I'll say, see what happens. Worst that happens is they become a little bit more iron overloaded. Well, actually, there certainly are some risk in septic patients about giving iron, but in the non-septic patient, I don't think there's anything to lose. So yeah, so my rule of thumb is if I'm not sure, I'll just try and see what happens. With the e-iron referral system, was there any inclusion or investigation reflecting a concurrent inflammatory process? Based on those deferred for iron infusions, what percentage was reflective of anemia of chronic disease? So, e-iron infusion was designed to pick up patients with simple iron deficiency. So, I was satisfied in approving intravenous iron if the ferritin was what you would expect the ferritin to be, with maybe a bit of give if the patient was obese. I certainly am not a favor of cutoff rates. But, my clinical acumen kind of it's pretty easy to spot those patients without any other contributing inflammatory conditions. If the patient, still looked iron deficient, but their ferritin was higher than I would expect it to be, or if there was anything else going on, those patients don't get approved. And, either, some other management was recommended, or if it's, it's not sure, then in those patients, a face-to-face visit was recommended, which I didn't have the figure there, but I think 8% of patients who were referred, we actually recommend a face-to-face evaluation. The iron will have helped their uterine contraction and platelet function. Correct. I agree. Regarding the heavy menstrual bleeding, perhaps pictorial bleeding charts are a valuable tool in every practice. There is consistency in evaluating the heavy menstrual bleeding. Yeah, it's actually, this was an issue, is we wanted to come up with a good screening, and actually the gynecologists were not that helpful. But, fortunately, the infusion nurses are actually nurse practitioners, so they have some clinical training, are pretty experienced in these matters. And yeah, it's not very reproducible, but I do trust them to do a good evaluation and to discern, those patients who are in fact having heavy menstrual bleeding versus those who aren't. How common are GI causes? Where would you put those in the list of common causes, malignancies? I can only speak to my own experience, and we don't see a lot of GI, but it's not because they're not out there. It's just, I'm dependent on referral patterns. So the OBGYNs and primary care physicians, are very aware of my services in the ER. GI, not so much. And I think they have their own facilities to give iron infusions. So it's, out there, it's probably more common, but of those patients referred to e-iron, probably not reflective of the true prevalence out in the community. Any experience with regards to heavy menstrual bleeding, GI bleeding secondary? No, not personally. I'm not aware of that. What is the place of erythroferrin in all of this? Well, erythroferrin has a very important place. I mean, it's the key driver that suppresses hepcidin in situations of iron deficiency. As far as I know, it hasn't have any clinical role. It's not widely available, but I'm sure maybe sometime there will be some clinical role for erythroferrin. As a consensus, what is a rational way to administer oral iron? Alternative day or daily dosing. So, I can only give my approach. As I say, it's pragmatic. I start with, tell patients, as I said, 1 a day in the morning, and if they're tolerating well, 2 a day in the morning. If they're not tolerating 1 a day, go to alternate days. And if they can't tolerate that, then intravenous iron. in non-anemic iron deficiency, while on oral iron in the late second, third trimester of pregnancy, not inevitably going to lead to iron deficiency in the majority of patients, pre or post-delivery. If this is the case, is there not an argument to be made for its use as a prophylaxis? Yeah, I don't know. I'm not sure. I mean, there was a review in Blood that came out, I don't know, 10 years ago that was very influential of management of anemia in pregnancy. And they proposed some guidelines which were not evidence-based as far as I know, but their recommendation was that an iron deficient patient in the third trimester with iron deficiency anemia goes straight to intravenous iron infusion. I mean, yes, it's going to take care of the problem, but isn't it a bit of overkill? I don't know. It depends how anemic the patient, how close they are to delivery. But a patient with mild anemia at 28 weeks is in the third trimester. I certainly wouldn't jump to intravenous iron. What is the utility of using formulas like the Ganzoni formula? Inflammatory conditions, in guiding iron replacement, you aim to provide the recommended dose and for the hematological parameters. I think, it's valid, but it's probably not required. I mean, at the end of the day, this isn't chemotherapy. We don't have to get the dose right milligram per milligram. You certainly want to give enough. And if you overshoot it a little bit, it's not the end of the world. Typically these patients, if they, the iron gets stored, it will get used later. What I teach the fellows is that they're welcome to use the Ganzoni formula, but really, you get a feel for what the dose is based on the hemoglobin. You give 500 milligrams as a starting point to replete their stores. And if their hemoglobin is, 10 to 12, they're probably another 500 milligrams. If it's 8 to 10, it's maybe another 250 milligrams. So, for me, it's kind of estimating, and it usually comes close to the Ganzoni formula. But, I think there's a lot of wiggle room. So I don't rely on formulas. I know Tom DeLaury from where's the University of Seattle? Portland, Oregon. He says that every patient who comes gets 1,000 milligrams. Everybody gets 1,000 milligrams, which I think is a little bit crazy. But anyway, it works for them. And probably most patients are taken care of. And I don't think he's poisoning any patients. The other formula I don't use. In chemotherapy-induced anemia, is IV iron better than oral? It really depends. I mean, I think the same principles apply. You'll start with oral in a patient who's truly iron deficient, but you're probably more inclined to not use oral simply because these patients are already challenged with the nausea, GI issues, and plus chemotherapy, they're probably already, frequently in the infusion suite. So yeah, very many patients I wouldn't bother with oral in that context. I'll just give them intravenous iron. And I think those are the end of the questions. Those are great questions. Thank you. I'm really grateful for that.
Thanks so much for going through all of those. Just to maybe, while we've still got quite a few people on the call, let me just quickly make you aware. I hope you can see that, but this has just been published now in the first month of the year. Guidance for gastrointestinal evaluation management for iron deficiency in our region, under the leadership of Wayne Simmons in Bloemfontein. So that's the whole process where we went through all the different settings and how should you scope and bidirectional scoping and all that. And yes, so maybe just a comment or two from my side.
Yes, please.
I think in terms of the alternate day versus the daily dosing, I guess it depends on what you look at. So there's a number of randomized controlled trials now that sort of showed equality in response rates, although you sometimes see that the early response rates with alternate day dosing is slower. and after 3 or 4 weeks, you might not achieve what you would achieve at 6 weeks, but generally at 6 weeks, you get to the same endpoint as what you would get to with daily iron in the iron sulfate. And tolerance varies. I agree with you. The proof of principle studies in Lancet Hematology and so forth showed very good, at least equal or perhaps better tolerance for the alternate day dosing. But one also has to look at the details. So some of these studies would give 2 tablets of ferrous sulfate alternate days, whereas some studies would give 1 tablet alternate days. So that's also just maybe a point to take into account what the dosing would be versus the daily dose, because of that hepcidin effect of the iron sulfate. I just quickly had a look on UpToDate. Yes, we love UpToDate in South Africa. And I see Michael Auerbach, who writes all the iron articles, and I'm sure you know him well as well. I see they give 2 options, daily dosing or every other day dosing, with no preference for one over the other. So that's currently, it seems to be still there. But what he does acknowledge is that differences in efficacy appear to be marginal. So similar efficacy, in his opinion, gastrointestinal side effects greater in the daily dosing, but I think that's something one can debate.
Yeah, absolutely.
I'm personally, I think and this is my last comment, I think one of the big issues with randomized controlled trials and also meta-analyses has been the difficulty with looking at comparing or let's say thinking about what outcomes are you looking at. And my concern's always with missing something. If you say maybe we don't see a great benefit with outcome A, B, and C, but you didn't actually look for outcome X, Y, and Z, that you may be missing something. And this is where I'm quite a strong proponent of also applying Bradford Hill's type of thinking and criteria to my approach. And if I look at the evidence of iron deficiency in pregnancy, even though we realize that some of those data are based on animal studies, I'm leaning towards giving the baby and the mother the benefit of the doubt, because we've got a strong biologically plausible rationale. We know that there's a lot of things in there. So I feel very strongly that at this point, the baby should get the benefit of the doubt, and for that reason. But I also acknowledge that we do need a lot more studies. The challenge, of course, is always, how do you do studies? How do you test a parachute with a good control?
Yeah.
And that's for me, it's a very similar situation there. You often have to rely on proof of principle, biological plausibility, dose effects, and stuff like that to sort of infer potential benefit. The few observational studies that we have, some of them quite large, all point in the direction of potential harm in some parameters, but they all have different outcomes, which makes it very difficult to compare in meta-analyses. So I find that a very interesting and very difficult area still. But yeah, I think I like the utilitarian approach. I'd rather give the iron and for the benefit of those who will benefit, even though I know that some people might not have any particular benefit from it. I also agree with you about I don't give 1,000 milligrams of iron to everyone. If a patient is not anemic, I only give 500 as a standard. I definitely don't give more. I also don't give more than 1,000 at a time as my general practice. I know you can, but I would, if they need more, I would then give them the other part a week later or so. Anyways, wonderful, Mark. Great to see another partner in crime with this phenomenal topic of iron deficiency. And I think we've got a lot to talk about going forward. We've got lots of people in South Africa very interested in this area. And you've really given us so much food for thought. Thank you for your time. Thank you for everybody who stayed the 10 minutes extra. We will look, but I think this might have been a record attendance. We had 220 people in the room at one point, and usually we don't go more than 200. So this was, you certainly you can certainly draw a crowd. And
Wow, I don't think so, but thank you. And I can just echo that I really enjoyed that, and it was great having this interaction, and that we only scratched the surface. I could list 10 other topics that we could have heated discussion with about.
invite and get you to attack some of those other 10 topics.
Absolutely. Only happy to. Thank you so much.
Thank you so much. Thank you, everybody. And we look forward to seeing everyone back again next week, Monday afternoon. Bye-bye. Thanks, Mark. Have a lovely evening.
Thank
Good
you.
visit.